Hello, 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 So the presentation okay, sir. Okay, sir. हाँ जी। सर अभी जयराम सर आए हैं तो कर दूँ कि ठीक जी सर ओके सर थैंक यू सर।
Good morning, respected teachers and my dear colleagues. The topic for today's Journal Cup presentation is Impression Tray Designs and Techniques for Complete Denture in Cases of Microstomia, a review. This was published by Hegde et al. In the Journal of Prosthodontic Research in 2012. Coming to the introduction, microstomia or limited mouth opening is often a sequel of conditions like scleroderma, post-operative head and neck injury, oral submucous fibrosis, trismus, surgical treatment of orofacial cancers, cleft lips, burns, and Plummer-Vinson syndrome. Before going on to the designs for microstomia, let us know more about impression trays. So, impression tray is defined as a device that is used to carry, confine, and control impression material while making an impression. Coming to the classification of impression trays. Firstly, based on whether they are prefabricated or individualized. So they are divided into stock trays and custom trays. So stock trays are the trays which we have in stock, and custom trays are the trays which we fabricate according to each patient. A stock tray is defined as a metal or plastic prefabricated impression tray, typically available in various sizes and used principally for preliminary impressions. A custom tray is defined as an individualized impression tray made from a cast recovered from a preliminary impression. It is used in making a final impression. The next classification is based on the materials used. So the stock trays are available as metallic trays and plastic trays, and the materials which are used for fabrication of custom trays are acrylic resin, tray compound, shellac, thermoplastic sheets, wax, and we can also use patients' old dentures as custom trays. The next classification is based on the impression materials used. So first it is the perforated trays and next is the non-perforated trays. So perforated trays are used when more retention is required for the impression compounds such as in alginate, and non-perforated trays are used in rigid impression compounds such as impression compound. Next classification is based on the application. So first used for edentulous patients, and next when the situation is dentulous or partially edentulous. So the difference between edentulous trays and dentulous trays are, in the edentulous trays the trays are more oval in shape and the dentulous trays are more squarish in shape, and they have more height so as to accommodate the teeth in them. The next category is the specialized clinical conditions such as microstomia, in which we use sectional trays. So coming back to the article, the problems with microstomia are difficulty in impression making, which causes discomfort to the patient, and all these factors reduce the accuracy of the impression, and these result in a fabrication of an improper prosthesis. So a loaded impression tray is the largest item requiring intraoral placement, because when we load the impression material in the tray, its size and height further increases. Wide opening of the mouth is required for proper tray insertion and alignment. Alterations and newer innovations of standard impression procedures are required so that we can make proper impressions in such special cases. So firstly, we'll discuss about preliminary impression in microstomia. So Loeb in 1984 used calipers to measure the arch width. What he did was he measured the arch width with the calipers, and with that width he selected corresponding impression trays. Then in that customized in that stock tray, he poured a cast and formed a matrix, and on that matrix he formed a sectional tray with a larger handle and divided the tray into two, and the larger part of the tray consisted the handle. So the customized plastic impression trays were sectioned into larger and smaller sections, and he used Lego building blocks, which are used by kids for playing, uh, to interlock these trays. So as we can see here, the larger part of the tray consists of the handle, and both are interlocked by Lego blocks. With the larger section tray, impression of two-thirds of the arch was made. The impression was trimmed and flush was removed, and it was surgically cut till the edges with a blade, and petroleum jelly was applied and it was again placed in the mouth. Then the second impression with the smaller tray was made against the first impression, and it was snapped and both the impressions were joined. And after the impression material was set, both trays were removed one by one and then approximated outside the mouth. Next is McCord et al. In 1989 used impression plaster, which they poured in the patient's previous denture. So this is only applicable if a patient is already a denture wearer. So the cast was constructed uh, with the patient's denture, and that cast was used as a diagnostic cast to make special tray. In the special tray, they made nick notches both in the body of the tray and in the handle of the tray. So these nick notches will help to approximate the tray later on. Next is the use of putty. Putty silicone is a flexible material, and so it can be used as a flexible tray. It is then washed with a light body silicone for more details. And dental stone can be used to stabilize the impression material. The preliminary casts which are obtained from this diagnostic impression and can be used for making special trays which are sectional and can be used for the final impression. Next is Dhanasom Boom in 2000. What he did was he used two trays for each arch impression. So the trays were cut anterior posteriorly, and as we can see here in the diagram, the trays were cut anterior posteriorly. In one tray he cut from the left side of the midline, and in the other tray he cut from the right side of the midline. So one tray will record the impression properly from the left side, and other tray will record the impression properly from the right side. Two impressions of each arch were recorded. So firstly, the right side of the impression was poured with dental plaster. So as we can see here in the diagram, the right side of the impression is poured, and then the left, when this cast is set, it is removed, and the left side impression is placed over the cast, and in the remaining area, another section of impression plaster is placed. And we need to hold this properly so that they don't distort while setting. Next is Baker et al. In 2000. What his idea was, he used more horizontal positioning of the tray rather than vertical positioning. So more horizontal positioning enabled more movements which are necessary to be made. So custom trays were there with a locking mechanism. So as we can see this hook attaches in this nut, and intraorally we can attach them. And in the handle also there is one more nut and its retentive area. So we can lock them inside the mouth, and after the impression material sets, we can separate the tray and again remove one by one, and outside the mouth we can approximate it again. Next is Cura et al. In 2003. He also used putty type of impression material which can serve as custom tray to make diagnostic impressions. The impression material was border molded to appropriate contour. So after the border molding and after the material is polymerized, any impression material like light body or even alginate can be poured on the silicone custom tray and then again reinserted in the mouth. Next is the sectional custom trays, fabrication and secondary impression. So the mandibular tray is sectioned into two. A, a stock tray is sectioned into two and the handle is removed. So handle is formed by autopolymerizing acrylic resin, and they have fins for reapproximation at the same time, and the handle is bent for proper grip. A steel tubing is incorporated in one half of the tray handle. So as we can see here, the handle is made and which is bent, and a hook which is U-shaped is fabricated with a steel tubing, and it has a housing on the other side of the impression tray which locks inside the mouth. This is another design for the combination of acrylic and stock tray. A separate acrylic block made with a metal pin or a piece of burr at one end to engage the metal tubing. So this piece of metal, we can also use a piece of burr which engages in the counterpart, and this the curvature here locks this metal part, and the tray is stabilized. As we saw in the first design, Luke, what his idea was, he recommended that the tray should be cut into two unequal sections rather than two equal halves, because he suggested that this idea can be done so that the labial frenum is recorded accurately. As we can see here, the trays are split into two, so the center part will record the labial frenum properly. Other designs are fins in the handle. So we can make fins like nick notches in the handle, and we can these fins will help in reapproximation of the tray. We can also add metal pins and burrs to join the tray. So here many holes are dig in the impression tray, which can be put in by metal pins and burrs. They can help in stabilizing the tray. Next is Cura et al. In 2003. They modified a metal tray, a stock metal tray. So what they did was they attached 4 pins uh, in the stock metal tray with the help of autopolymerizing acrylic resin, and the pins were fitted symmetrically and parallel to the midline. In the mandibular tray, the long pins were placed distally and the short pins were placed close to the midline. In the maxillary tray, short pins were placed over the residual ridge and long pins were placed close to the midline. A milling device was used to evaluate the pins' parallelism. So as we can see here, the tray is cut into pieces with a steel burr, and it is joined by acrylic resin block. So this is the acrylic resin block, and these are the burr pieces which are attached. So this acrylic resin block will go over it and will stabilize the tray. So this type of tray is folded in the horizontal plane. Next is Gekili et al. In 2006. So their idea of sectioning the tray was completely different from other researchers. So what they did was they sectioned the tray mesiodistally from the middle of the palate, and they placed pieces of tungsten carbide bar divided into three, and they placed one piece on the right side of the crest and one piece on the left side of the crest and one in the palatal midsection. So these bars were fixed by autopolymerizing resin, and the sectional impression was made in mesiodistally sectioned trays. So the posterior impression was taken first, and then the anterior part of the impression was made. Coming to the review of literature, firstly, a simple method for fabricating custom sectional trays for making definitive impressions in patients with microstomia. So they fabricated the maxillary and mandibular trays, sectional trays, by using autopolymerizing acrylic resin. So what they did was they made handles larger than the normal trays. So minimum dimensions of the handles were 13 mm in height, 10 mm in length, and 10 mm in width. So the larger handles were made to incorporate metal sleeves of the die pins. So these are the two dual die pins used. So as we can see here, this is the sleeves of the die pin and these are the die pins. What they did is they made an assembly of the die pin They interlock two dual dipins in such manner so that they can approximate and they can act as a locking system. So they formed regular custom tray with the help of acrylic resin, and they sectioned the tray from the midline. And in the handle, they made a area to accommodate the assembly of the die pin. So the assembly of the die pin was assembled in the handles. Only the sleeves was fixed with the dual with the acrylic tray, and then this assembly acts as a locking mechanism. In the posterior part of the tray also they made a horizontal bar which locked in the posterior part of the tray and stabilized the posterior part of the tray. The next is a sectional impression tray technique for an intraoral fibrosis for an oral submucous fibrosis patient with limited mouth opening. So this describes the fabrication of a split impression tray to make a secondary impression of an edentulous patient having oral submucous fibrosis. So firstly, spacer wax was adapted in the tray, and then then an acrylic special tray was formed, which was cut in zigzag manner from the midline. This was done so that the other part can be approximated and interlocked later on. The handle of the first segment contained two tapered die pins, and the other part of the handle was made over it so that that can also act as a interlocking manner. So the sectional border molding was done for the both trays separately, first from the right side and then from the left side, and then then these trays were interlocking mechanism was used to join the trays, and the final impression was made. And petroleum jelly was attached in the interlocking area so that later it can be separated. So this, after making the final impressions, these can be taken outside of the mouth and reassembled again. Same mechanism is also done for the mandibular trays. The next is the preliminary impression techniques for microstomia patients. So they suggested various tray designs for primary impressions in patients with microstomia. So these designs were other designs which were there in my master article. So firstly, they use flexible impression trays. They also use silicon putty. So this is an impression obtained with silicon putty. So they stabilized it in a mold, and then it was poured. The next technique was using of plastic trays. So the trays which are used for fluoride application are flexible and they are small enough, so they can be easily folded and used for primary impressions in patients with microstomia. The next technique is reinforced flexible impression trays. So what they did was they used putty silicon material and they reinforced it with the acrylic U-shaped device with a crossbar connecting the two arms. So this is a device which is U-shaped and it is connected with the two arms are connected with a horizontal bar. This is reinforced over the silicon putty material so as to stabilize it. The next technique is the use of magnets. A magnet was embedded in the acrylic formed around the handle of one half of the stock tray, and a metal plate was attached on the other half. So as we can see here, a zigzag form of handle of the tray is made with acrylic, and metal on the one side metal is attached and on the other side magnet is attached, so they can easily approximate when later on approximated extraorally. So coming to the conclusion, one of the difficulties in placing the tray is placing the trays intraorally in the patients with microstomia. Trays in sections allow for ease in placement and removal and then reapproximation extraorally. The prime requirement for a sectional tray is its stability inside the mouth, and when it is taken outside and poured, so it should also bear the weight of the stone when it is poured. These are my references. Thank you.